Dr. Cassie from NAVC's Vetfolio and the host of Vet2Vet. Knowing what to say to clients when delivering difficult news, it never gets easier. In cases like canine lymphoma, explaining the options is only part of the conversation. Joining us today is Dr. Kim Galligher. She's a small animal vet in Pennsylvania and practices using low-stress handling techniques and offers comprehensive and compassionate care to her patients. We'll also be talking about Laverdia CA1 Vertinexor tablets. Laverdia CA1 Vertinexor tablets is a conditionally approved drug. An understanding of what conditional approval means is crucial. Conditional approval means that the necessary safety data, when used according to the label, has been demonstrated, and that a reasonable expectation of effectiveness has been provided to the FDA, and that the drug is manufactured in accordance with full approval standards. Reasonable expectation of effectiveness means that the product is reasonably expected to provide the intended effect when used under conditions of use described in labeling. A pivotal field efficacy study is being conducted to reach full approval within the 5-year window allowed. Conditionally approved drugs must be used on label. Hello, Dr. Galligher. I'm glad to have you here today. You speak a lot about compassion, and that's really what we're here to talk about today.
Thanks for having me, Dr. Cassie.
We're talking about recent advances in management for canine lymphoma, and I understand this is an issue that hits kind of close to home for you. Can you tell us a little bit more about your experience with canine lymphoma?
Sure thing. Sadly, I have some pretty deep experiences with canine lymphoma, so why don't we just jump in? Let's go back to 2009 and talk about my first dog, Lance. He was my first heart dog, and may he rest in peace. You know, he was the dog that shows up to your practice to be evaluated for a lameness by a rescue and to be euthanized because they couldn't afford to repair his torn cruciate. But your boss interjects and says, "Hey, I can't euthanize this dog. I'll repair his orthopedic injuries if you adopt him, and you can pay me in the form of a case of rum." We've all been there, I'm sure, but after 5 years of coming home with me, he developed this odd 3-dimensional rash. Turns out to be epitheliotropic lymphoma, a form of T-cell lymphoma. And at the time, this disease had a prognosis of 4 to 6 months. Not sure what would take him first, his orthopedic disease or his cancer. I reached out to a friend and a classmate, Dr. Rebecca Risbin, who was an oncologist. She started him on an oral chemotherapeutic drug. We gave it at home, and it's the same one used today to treat this form of cancer. And she recommended a novel drug to help with the untoward side effects of the chemotherapy. It was called Cerenia. This was a new drug. I had never seen it before, and she said that oncologists were using it like Tic Tacs, and it was working great to prevent nausea and inappetence. I was so nervous to give it to him because my only experience with meds like this before was metoclopramide, and, well, I was just afraid I was going to cause other injuries with it. But we gave it daily with his medications, and it worked great. Do you remember the feeling when we didn't have Cerenia? And now we do, and how it changed the face of our medicine?
I feel like I've reached a point where I look at some of the drugs that we use to treat things now, and I'm like, this didn't exist when I graduated, and it makes things so much easier.
It does. It does. The face of medicine has changed a lot in the last 20 years, and I hope we can talk about some of that today. As his disease was progressing and the clinical control of his disease with his chemotherapeutic drug was shrinking, the cancer was winning the battle. And she offered for me to put him on steroids toward the end. But as a family, we had to look at our patient and our pet. He was an 8-year-old, 150-pound Neapolitan Mastiff with advanced osteoarthritis in his knees from his unmanaged cruciate injury and hip dysplasia in the contralateral hip. As a family living with this lovely soul, we thought it wasn't a fair option for him. Historically, another oncologist, Dr. Clifford, had taught me that when it comes to lymphoma, B is better and T is tougher to treat. With Laverdia CA1, we have found the research trials show us that these T-cell dogs are responding better. And today, Lance would have been treated with this drug, and we could have given him more options. Eventually, his disease continued to spread, and it spread to his eyelids, giving him functional blindness. He just couldn't see. His lids were all swollen. And we humanely advocated for him to let his little soul rest and be at peace. And most importantly, to remove his fear and discomfort from this horrible cancer. Wow, it so sucked. So it took me a long time to heal from those giant footprints left on my heart. But one day, 2.5 years later, my husband was ready for a new dog. And we went to the local rescue, and there was this group of 9 pit bulls that had been living there for over a year. And there was one in a cage all by itself. And when we walked by her, boy, she didn't even respond to us. She just laid in the back. She was almost immune to visitors. And well, the rest is history. Fast forward 12 years, and that takes us to this fall. My son so sadly told me she's been panting all weekend and she won't go outside. And the worst of all, when she did get outside to go to the bathroom, wow, she laid down in a muddy puddle and she wouldn't get back out. Whew. We diagnosed her 2 days later, back in this past October, with a hemoabdomen and sadly a splenic mass. Frantic, I reached out to Dr. Clifford and turned out it was hemangiosarcoma. Cancer sucks in all forms, but this disease really sucks. So I'm right there in the thick of it with all your clients. You've now met my 2 dogs since I graduated from vet school over the last 20 years, both of them with cancer. That's a bummer. But I'll tell you what, it's most important that they didn't know they had cancer. And sure, I could be checking PCVs or serial chest x rays and ultrasounds, but what will that change for my Laura? She currently has no idea she's living with cancer or even has it. And I'm really happy to keep her that way. Some of you may be wondering how my Laura is still here today. Well, she's exceeding her prognosis, and I'm really enjoying every moment with this ticking time bomb.
Thank you so much for sharing those stories. I mean, that's like you said, that's a huge bummer. 2 dogs back to back, both with cancer, both very difficult to treat. And, it's so hard to live with a ticking time bomb. So thank you for, walking us through your experience and helping those of us who maybe haven't been through something like that personally to understand what we're giving to an owner when we give a diagnosis like that.
It's really hard to be human and to adult. And I really find that if we can remember that on a daily basis and allow our teams to be present when they're at work and just be human, we'll have a much better connection with our clients and their families, and they'll understand that we're being present with them.
Absolutely. Absolutely. And, not to make you walk through all of these emotions again, but, since I appreciate you so much, you really putting your experience out there. Can we talk about it from the perspective of a practice owner and a practicing veterinarian, and then you being someone who's been there personally with a dog diagnosed with lymphoma? Can you talk about some of the emotions, some of the experiences we should expect and we should be aware of when we're delivering a diagnosis and we're formulating a treatment plan for these patients?
Yeah, definitely. Look, life is busy for all of us. And well, especially since COVID in our industry, more people in this country have adopted pets for the first time, and thus their first experience with our pet care industry. They're looking for pet care on the same level of their human health care. And our customer service representatives are challenged to stay motivated by compassion when the phones just never stop ringing and they're limited by time and appointment availability. So when a client calls our front desk, our team is now given the opportunity to help this family and their pet. We always have to remember that. The phone rings, it's not annoyance, it's actually an opportunity to help. Um, the client says, I found a lump or any change clinically, and we don't know if that lump was noted a few hours ago or a few weeks ago. This is out of our control. But time is of the essence, and these conversations need to be handled in a really professional manner. We all need to remember to be judgment free, and that's a hard thing to do. Especially with lymphoma, time is always of the essence. We need to make sure that we hear these key pieces of information, and we need to have previously educated our team that when there's a suspicion, what must follow suit. This has to be a same-day sick appointment, not a few weeks down the road when they have a day off or we have room in our schedule. The patient may not be alive in a few weeks. Dr. Clifford has always taught me to never let the sun set on a patient with lymphoma. Time really is of the essence. And sadly, with lymphoma, or just a suspicion of a diagnosis of cancer, it comes with a hefty stigma. And I'm sure many of you have discussed this with your clients on a daily basis. The gift of chemotherapy is not financially feasible for everybody. And the fear of the pain and suffering seen by our human counterparts undergoing chemotherapy alone sometimes draws the line. We need to calmly educate our clients of the major differences between human and veterinary oncology. Ethically, we are not able to reach a cure for this disease. Medications and protocols used are not exactly the same to that in people. And we cannot ask our pets who cannot advocate for themselves um, to endure daily pain and suffering today for a brighter future in the end. Our goal is quality of life, not quantity of life. Just like our patients, we want our clients to sleep at night without regrets. We've all done our best. Sadly, the statistics show that 80% of our families will decline the gold standard multi-adjuvant chemotherapy for lymphoma. This could be provided either at your practice or by an oncologist by referral, and the general cost for that is around $5,000 to $8,000. Prednisone is cheap, and maybe 50% of our patients will respond to it, and they may survive 1 or 2 months. That's better than weeks. Laverdia CA1, with or without a low dose of prednisone, may cost a couple $100s, and we may see survivals of up to 3 months, and in some cases, up to 9 months. It used to be that when your pet started chemotherapy, the treatment cost was X, like a lymphoma package. A majority of oncologists today are doing it differently, thankfully. You now pay as you go. Yes, the total package cost is similar um, if you were to complete the entire course, but there is no longer the pressure or fear that you should keep treating when your heart says it's best to stop, but your wallet says you're already locked in.
You touched a little bit on client communication there right at the beginning, and training CSRs on how to communicate with clients when we get that my dog has a lump call. Can you talk a little bit more about some of the communication that may help clients navigate these really difficult technical decisions and emotional decisions?
Well, I want to first start just saying when I got either one of these diagnoses, I forgot that I was a veterinarian. And I just had to sit there and be with myself and be like, take a breath. What is happening? I don't, all of my knowledge about all the things we're talking about went right out my head. And I just had to talk to somebody who I trusted to be like, okay, how do I do this? These clients that come in, boy, so let's think about it. They called and there was a lump. And from the beginning of the experience, it was a time sensitive emergency. So now these clients are so conditioned and fearful of changes. Fluctuations to their patient's lymph nodes is really like they're on it. They know to call if they see any changes. It's almost like they're always waiting for the other shoe to drop. It's really important that we're present with people. We listen carefully to them and we let the clients lead us. We often forget about that as veterinarians. You know, you have this patient who comes in, you see what they come in for, and then you examine them and you're like, but all of these other things are problems, and you forget why they came in. And sometimes people are really upset about that because they really just wanted the nails trimmed, or they really just wanted you to look at this little lump when the patient has multiple other things going on. And our diagnostic brains tell us we need to get into all these other things, and we forget about why they came in. These oncology patients, they really need to be heard. they're really outside of their comfort zone and they're fearful, and you're their only lifeline to help them feel comfortable. So it's really important to let the clients lead us. Don't forget that we're the doctors here, and we have to be confident in our plans, but we need to listen to what they want for their loved one. Chemotherapy, like I said earlier, it's a gift, rather than something to be afraid of, and we need to tell people that it's okay and listen to why they're afraid, and talk to them about why it's different. They can stop whenever they want. They have a say in the process. And our goal again, we're not looking for the cure. I mean, we would love to have the cure. It just doesn't exist for lymphoma, unfortunately, in our pets. But we don't want them to even know that they have it. And that can be really overwhelming. We try to get people, in my opinion, if I can just get them to go for a consult, I think that that's the first step, because I know that our oncology teams are really good at educating and continuing that thought process that I've planted with them, especially in the dogs who are sick, because I know that if I can just get them in at least for an LSPAR injection, I feel like they feel so much better. After that, within like 24 hours, their dog is back, and they might think, you know what, maybe I can move on and maybe I could do more, because they're just waiting for that other shoe to drop and their dog to just not be able to do it anymore. If they're doing well, we want to keep going. We want to support the patient, listen to the client for their feedback. Ask them, how are they feeling about their pet's quality of life for their loved one? We really need to be collaborative in our conversations, and the goal needs to be patient centered, not based on what the numbers show us or what we suspect. We need to know what's happening with that pet. Remembering what the family's goal is and focus on transparency. They don't ever want to feel like they're not, going to be able to predict what's coming next. If we can have the whole team educated about how we as a practice handle different conditions, I find that that allows them um, to be more transparent. I, as a medical director and practice owner, really enjoyed creating strategic operating plans for our teams. That way, we had it on a piece of paper, and clients could, everyone at every level. The clients don't get it, of course, but everyone at every level could say, hey, so and so is on the phone. How do I predict that this may look? Now, the SOPs may always be changing as medicine continues to evolve, but it's something that's helpful so that you don't have someone at a different stage of your communication levels saying something that's really out of place.
Absolutely. I love your approach there that especially when it comes to the client communication of our goal is to make your pet not realize that it has cancer. And I think that really kind of frames chemotherapy in animals the way that we want people to perceive it, because it is so different between animals and between humans, that if we're doing this so that your pet no longer knows that it has cancer, then clearly they're not in terrible pain or something like that, because then we wouldn't be doing it. Because like you said, our goal, we're not trying to cure this, we're trying to give them quality of life, and that's what we're doing with this chemotherapy. That's such powerful messaging. I know for me especially, I'm going to take that and put it in my hip pocket and use that the next time I have to have one of these conversations. And certainly that needs to be echoed at every level, because these are high touch patients. They need a lot of follow up. So can you talk a little bit more about incorporating the whole team into that messaging and that communication?
Yeah, definitely. I like to always say this, and I hope that everybody out there feels this way. Medicine and dealing with all of these emotional topics can be very overwhelming. And sometimes I think when we're in practice, we can allow ourselves to feel pretty isolated. So try not to do that. If you live in a rural area or you're just slammed and time limitations have isolated you, just try to remember that you're not alone. If you can send an email or leave a voicemail, establishing connections in our profession will help you along the way every day. Ask yourself, does your hospital have SOPs in writing, I find myself that they're very helpful. Everyone's on the same page, and it provides continuity of care within our practice because most of our practices are multi doctor practices. Um, my management and leadership training has taught me that everybody learns differently. So having a written reference is ideal. And you're not stuck with your SOP. Like I said, it evolves as your practice evolves. Um, and the other really nice thing about it is it allows us to not lose our patience to follow up because everyone at every level knows the importance of their position in that. So the way it works on our SOP is once we have a suspicion, we bring them in, same day sick appointment. We collect a detailed medical history and a physical exam is completed, nose to tail. We make a body map and measurements of all the enlarged lymph nodes. We're going to complete fine needle aspirates and cytologies. I'm going to look at them in house and we're going to send them out to confirm at a reference lab. We request that all of our doctors collect at least 6 to 8 extra unstained slides to be held at the lab for phenotyping. Pending our exam findings and our clinical exam findings and the budget of the family, we may be considering lab work, a complete blood count and chemistry, urinalysis, chest x-rays. If they're sick, maybe an ultrasound and bone marrow aspirate. If we have a diagnosis of lymphoma, then we're going to go ahead and add on immunocytochemistry. This will tell your oncologist if it's B or T cell lymphoma before their initial consult, and their conversation and plan can be more closely tailored to your patient's needs. If you currently don't have a relationship with your local oncologist, today is a great day to establish one. I will send a complete report of all the items that we just talked about and pretty much say, hey, what do you think the next step should be? How soon can they get the patient in oncology? Is it ill? Is it stable? The statistics show that 80% of our patients with lymphoma are healthy and asymptomatic aside from their lymphadenopathy. But if they're ill and have anorexia, fever, weight loss, or other GI symptoms like diarrhea and melena, well, then we're going to have to do things a little bit differently. Is this a new diagnosis or a relapse? And are they interested in seeing an oncologist? The conversation must be collaborative. The goal, like we said before, is patient centered. Try to remember to hold off on initiating prednisone if your patient is going to seek oncology. This can really change the prognosis of CHOP therapy and should not, if we can avoid it, be a knee jerk reaction.
Absolutely. I love the idea of SOPs and uniformity and collaborative care because it really lets us give that comprehensive treatment plan to our patients from the get-go, and it kind of takes some of the uncertainty out of it, because of course our client, our pet owner, is experiencing so much shock and uncertainty in that moment, and as you expressed to us earlier in this conversation. So being able to say, this is the plan, this is what we're going to do, this is what it's going to look like, here's what we're thinking going forward, and giving them a really comprehensive idea of what to expect has to provide at least some degree of comfort for people.
I always say I feel better once I have a plan.
Absolutely, absolutely. And don't we all, especially I know for, I don't know if it's just a veterinarian thing or if it's just a me thing, but like those SOPs and those algorithms, those are like my security blankets.
My brain's kind of like a kitchen cookbook. So that's how I kind of go through my mind. So I just put it out in writing so we're all on the same page.
I love it. I love it. Well, we've touched on, the importance of having a plan in place. And then we've kind of briefly mentioned Laverdia and some of these other tools, and how lymphoma treatment has changed here recently. Can you talk about that a little bit more? What has our treatment, our kind of toolbox looked like or our recipe looked like in the past, and how is it changing now going forward?
Yeah. So as we discussed, I've been around this industry for over 20 years. And well, the practice of medicine has evolved quite a bit over that time. And I like to think about it like a toolbox because I am also a house call veterinarian. And so I think about my little toolbox that I take with me on my house calls. And I like to think about it when I talk to people like, are you operating out of an old beat up toolbox or have you evolved to a nice, shiny Craftsman series toolbox? And well, with time comes experience. It's hard. Change is hard. And what will it take for you to change the way you manage lymphoma in your private practice? Well, it hasn't changed over my career until now. So let's jump in and look at it. In private practice, Laverdia CA1 is for the patient who declines CHOP therapy, either at your practice or by referral, but requests continued care. This expands access to care by giving us the ability to capture and care for 80% of our lymphoma patients that decline CHOP therapy. That's dramatic. Historically, if our family is limited by the distance of referral, cost, or just the stigma and fear we talked about earlier, listen to the family and go with your tried and true palliative care, steroids, pain management, and gastrointestinal protectants. We always have that to offer. Prednisone alone at high doses can be offensive to some and contraindicated to those with other comorbidities. But now we have more to offer. Laverdia CA1 twice weekly at home, maybe with or without low doses of prednisone. Sometimes those low doses of prednisone are very helpful because Laverdia CA1 does have some mild side effects. They're generally GI side effects, anorexia, weight loss, vomiting, lethargy, and diarrhea. But in the trials, fortunately, they were so mild that none of the dogs had to go off trial, which is great news.
Yes, that is great news. Also, good to just know about some of the less common side effects: elevated liver enzymes, thrombocytopenia, anemia, lymphopenia, and neutrophilia.
How else can we use Laverdia CA1? Maybe it's the family that's on the fence regarding referral, and their patient is not currently well, but is one that responds to Laverdia CA1. And the family may now see the light at the end of the tunnel, and maybe they'll reconsider referral for CHOP now that their friend is back to them. Is it the patient that's awaiting referral, but it's a few weeks out? Because oncology is booked 4 to 6 weeks later. And you know what? Without anything, they may not make it to that consult. So if you reached out to oncology and they're on board with starting Laverdia CA1, this gives us a safe bridge to potentially slow the progression of disease until CHOP can be initiated without impacting the patient prognosis like steroids can. It's also for the patient that discontinued CHOP because maybe they had side effects that the family didn't like, and it'll buy them time and slow progression of disease. Or the patient that's had a relapse and they're not pursuing Tenovia, or it's not an option for them. Laverdia CA1 is a great option for them in the comfort of their home twice a week.
Amazing. So exciting to have new options to treat this disease. Because like you said, it's been, we've had the same options for so long. So to be able to offer something new that may open the door for, additional treatment down the road for our patients is super exciting. Of course, we're changing now our traditional recipe, our traditional toolbox of treatment for lymphoma. We touched on this a little bit earlier when you noted there was this new GI drug that they were going to put your dog on. Along those lines, what are some of the challenges we face when we talk about changing our toolbox?
Yeah, I mean, it's really off-putting, and I think it can be overwhelming for many. And let's talk a little bit about that briefly to just kind of set the scene, I guess. Talk about the medical advances that have happened over the last 20 years that I've been in practice. So, kind of when I was in school, trilostane was what the dermatologists to use to treat alopecia X, those naked elephant looking little Pomeranians. Well, now we use it for so many more things in Cushing's disease. And how much safer are those dogs than when we had them only on Lysidren? Um, Levetiracetam was only available on brand name. And the neurologist We're the only ones who could afford to use it. We never had it in private practice because it was just too expensive. When was the last time that you had to give a methylpred or triamcinolone injection since Cytopoint came out? How great is it to not worry about inducing other secondary endocrinopathies while trying to treat a different condition? So I'm redoing my due diligence on this one. Um, I've attended both live and webinar based continuing educations. I've checked in on the drug websites and reviewed the science. I've been talking with our nurses, different veterinary colleagues, boarded specialists, and the pharmaceutical sales reps to get smart on how and why we need to use this drug. One of the things that I really realized is for sure is that if you put 10 veterinarians in a room and you ask them a question, you're sure to get 10 different answers. And it's okay to try new things. And when you start to get more familiar with how things go, you'll be more familiar and comfortable to use them again.
I love that, because you're right. It does take a lot of, kind of a lot of time and due diligence to really understand how to use something effectively and have it work in your hands. And like you said, there's no magic bullets. It would be so nice if there were, but when you kind of let the drug off the hook and go, okay, I'm not expecting this to be a magic bullet. So how can I incorporate this in a way that improves my practice?
Right.
I think you end up with a lot more success that way. At least I do.
Yeah, I think that, we live in a world where we want something to work instantly. And we do need to practice with things, and practice makes perfect. The more you give it a go, the better the outcomes may be.
Any safe handling considerations that we should make sure clients and staff are keeping in mind?
That's a great question. We want to make sure that everybody feels comfortable with handling this medication. In our practice, the medication sits in our pharmacy next to all of our other pharmaceutical drugs. The staff are directed to wear chemotherapy resistant gloves when packaging the medication. It goes into our normal dram bottles with a normal label on it. Out of an abundance of caution, families are advised to wear the same chemotherapy resistant gloves when handling the medication, feces, urine, saliva, or vomit. Children, pregnant, and lactating women, or those reproductively active, should not handle this drug. The medication comes in 3 sizes that are color coded. This is really helpful when educating our clients because we can tell them to give one of this color and one of that color. We do not want to be crushing or splitting pills.
Okay, so, certainly good safety considerations to make sure we're handling this correctly, but overall, a really exciting option for our patients. And Dr. Gallagher, I want to thank you so much for coming on this Vet2Vet with me today and helping walk us through some more information about Laverdia CA1, but not only that, some of the emotions surrounding a cancer diagnosis for our clients, thinking about their pet, for us as a team, making sure that we're addressing their needs. And also something that maybe we don't think about a whole lot as practitioners is, kind of that gut reaction when you're thinking about implementing a new drug. So I just really appreciate the well-rounded conversation today.
Dr. Cassie, thanks so much for having me. It's always fun to share our experiences and get real with somebody about what it's like to practice veterinary medicine on a day-to-day basis. So thanks so much for having me here today.
And thank you to Decra for partnering with us for this edition of Vet2Vet. Check out nabcsvetfolio.com for more of our Vet2Vet discussions on various topics in veterinary medicine. And remember, if one animal is better off because of you today, it's a great day.